Okay, hi. Hi, everybody, and welcome. Thanks very much for coming to the Maternal Health, the Hidden Public Health Epidemic for Maternal Health Matters organisation, and a partnership with the Australian National University Gender Institute, of which I'm on the management committee. My name is Sally Moyle. I'm an honorary associate professor at ANU, attached to the Gender Institute, and really excited to welcome you all to this seminar. Before we start, of course, I'd like to acknowledge the country on which we're all respectively meeting. I'm sitting on Yarrago land outside of Canberra, and I know that many of you will be participating from Canberra with the Ngunnawal and Ngambri people's acknowledgement there. So feel free, if you're joining from around the country, to put your the land on which you're coming to us from in the chat and make your acknowledgement there if you'd like to do that. But I would like, on behalf of all of us and from all of the lands that we're meeting on, to acknowledge the traditional owners of the land and pay respects to elders past and present, and note that the land on which we're standing in Australia has never been ceded. So welcome to you all. I'm really excited to be part of this seminar today because of, the notion of maternity being such a site for women's health, for structures around gender equality, for paid work and care norms, and for the creation and the reproduction of gender norms across our society and across the globe. And I know that at the time when people have kids, they often, because there's no real role models for gender norming around parenting when you're first a new parent, people often fall back to traditional gender norms that mean that progress towards equality is much slower. So I do know also that maternity and having a new kid is a real site for accelerated change towards equality. And I think that it'll be really exciting to have a look at this, to hear from the speakers at this seminar this afternoon, to hear about the thoughts about how we can use maternity as a site for women's wellbeing, gender equality, and more equal gender norms through society. So I'm really excited to be here and like to thank you all for joining us. And I'd like to pass over to Joan. Thank you.
Thank you, Sally. That's great. And it's been terrific to coordinate with the Gender Institute. Really appreciate your help with this. And so I want to invite Mary Kirk from the Maternal Health Matters to give an outline of Maternal Health Matters and our reason for being, our work. And Mary, if you'd like to say a few words.
Thanks, Joan. Thank you for the opportunity to talk about Maternal Health Matters. In 2008, there was a group of interested people, myself included, who were approached by the White Ribbon Alliance, which is an international organisation that is committed to respectful maternity care. There's a view globally that problems in relation to respectful maternity care, that being care that is both respectful emotionally and socially, but also based on evidence, was a low resource country issue. But what we know is that globally there is an issue for women that, irrespective of the socio-economic setting, all pregnant women and their babies during pregnancy, childbirth and the postnatal period have a right to optimal woman-centred care through a holistic human rights-based approach that provides a respectful birth experience and positive outcomes. Now, throughout Australia, throughout both high-resource countries and low-resource countries, we have this phenomena of too much too soon and too little too late, that in high-resource countries, women are exposed to high intervention rates, and then in low-resource countries, it's too little too late. And it seems to be, the evidence tells us overwhelmingly that the healthier you are, the more likely to be the wealthier you are, the more educated you are, the more you should likely be to have a normal birth and outcomes for you and your baby. But it's reversed because of our high intervention rates. But in low resource countries, it's absolutely reversed, that they experience too little too late. So from that came a social movement to bring about a human rights-based approach to birthing and to respectful maternity care. So in Australia, we were approached in 2008 and we established the organisation in 2009. We started off as Safe Motherhood for All because we had issues around the connotation of white ribbon in Australia, as opposed to that same connotation wasn't global. And so we started off as Safe Motherhood for All, but we've matured into the space. And so we've taken on the name of Maternal Health Matters in more recent times, and for both of its meanings, in that it does matter and matters that pertain to maternal health. Most especially, our imprimatur is respectful maternity care. Membership of the organisation is open to all. It started off as a social movement, and that's the way it should be. What can we do systemically to have a difference? I suggest that every one of us, advocate to have the elements of respectful maternity care embedded in accreditation standards. That is something that is across the whole health system, and every service works its butt off to get accredited. But we've tried and we've tried. Unfortunately, there's only, as far as advising the Commission, it's medicine that advises the Commission. But there needs to be a big social movement about having the elements of respectful maternity care embedded in accreditation standards for maternity services. That's one thing that will make a difference. We've got to go to policy, we've got to go to service delivery, and we've got to go to service planning to make a difference now. The professions can't do it on their own, and we can only do it with women. And that's what's been great about these presentations. Every single one of them is based on what the women said. But respectful maternity care is so embedded about the women. And that's where we need to focus, put the woman back in the middle of the table and demand that that's where she is. That is a picture of maternal health matters. So thank you, Joan.
Things for all of our participants. But before I go on with those, I just want to read out kind of working rules that we have for today in terms of our approach to maternity care and inclusiveness. So maternity care is inclusive of the diverse experiences of women and their social circumstances, which necessarily includes the experience of family violence, cultural and religious backgrounds, disability, sexual orientation and gender with which they identify. We recognise that individuals have diverse gender identities, and some people who become pregnant and give birth do not identify as a woman. The term woman is used throughout this seminar to refer to the person who becomes pregnant and gives birth. So our first speaker tonight is Natalie KonYu. She's a writer, academic and editor whose work has been published nationally and internationally. She's the author of a relatively recent book called The Cost of Labour: How Women Are Trapped by the Politics of Pregnancy and Parenting, and the co-commissioning editor for several books about unspoken aspects of women's lives. So we invite you, Natalie, to give your presentation.
Thank you, Joan, for that warm welcome, and thank you for inviting me to be part of the panel. So I'm going to read a little bit from the book and then share a few slides as well. It began with a trembling in my legs. I remember being on the sofa watching TV and noticing that my legs were shaking. They were still trembling when I went to bed. I couldn't make them stop. I was about 8 weeks pregnant and my body was doing all sorts of strange things, but this felt different. I hadn't read about trembling legs in any of the books my friends had given me, hadn't seen it listed as a symptom of early pregnancy on any of the websites I'd been checking. My husband called a locum who told me I was anxious and gave me a Valium. I went to sleep, woke up at 2 a.m. and tossed and turned for the rest of the morning, my legs doing a cha-cha without my permission. This went on for days. I couldn't still myself. I grew increasingly anxious and oscillated between thinking that the tremble in my legs was caused by pregnancy and worrying that it was caused by something that could potentially harm the pregnancy. I spent hours on the pregnancy hotline. I tried doing guided meditations at night to calm myself before bed. I worked from home, embarrassed about this body I could no longer control. The day before I found out I was pregnant, I'd been out from 8 a.m. to 11 p.m. at work and then for photos for an anthology I just co-edited, which is a few months from being released. I was exhausted, a deep kind of tiredness that I'd never experienced before, and it took me almost a week to realise that my period was late. I remember I felt my world shift after I saw the second pink line materialise. It was as if I was looking down from a path made of stone, and suddenly, with a great grumble of rock, the path moved and I was staring down a road I'd never seen before. Prior to this, I'd known where the road was heading, into work, a career, writing. Now I was facing a different direction and the road petered out into darkness. After the shock had worn off and my husband Rob and I had a chance to talk and think and imagine together, I was excited. Kids had always been part of our one-day plan back then when we were living in Perth and started dating. And I've always been plucky, born in two cultures, Mauritian and Italian, that prize and revere children. I've always loved the feel of a newborn in my arms, have always thought kids were fun and silly and wonderful. Parenthood had always been on the horizon, but we'd been so busy that the horizon had become a faraway place. Now suddenly it was here. The public holiday was the first time we'd had to sit together with our new horizon. We went to all the pregnancy websites we could find, trying to figure out how far along I was and when the baby would be born. We got out of bed late and went for a bike ride. I felt a pang of nausea and we stopped for a coffee and a slice of carrot cake and the nausea went away. Easy, I thought, simple. We figured out that in my second trimester, we'd be in Vietnam for our holiday. We thought that would be no big deal. We didn't even think our planned journey to Sapa, 10 hours by train, northwest of Hanoi, would be a big deal. Easy, we thought, simple. Of course, things became less easy. My nausea worsened and could no longer be cured by a nice slice of carrot cake. I became more tired than I'd ever been. On top of that, life was busier thanks to the anthology's upcoming launch. I flew to Sydney for radio and TV interviews when I was about 10 weeks pregnant. I was asked to write for The Guardian, all on top of my full-time workload. The public holiday, Rob and I had looked for a doctor in our area that specialised in obstetrics and found one up the road. We'd visited her the next day and she started me on the battery of blood tests to confirm the pregnancy and check my health. In our appointment, I told I'd been taking NDEP for years to treat chronic pain resulting from a back injury in my lower back. I'd had operations and done a pain management course, but the NDEP took the edge off the pain I felt daily. Rob and I had read that NDEP was not a drug that should be taken during pregnancy, so I'd stopped taking it the day before our appointment. That was fine, she said, nodding. She spent more time fretting about our plans to travel to Sapa than anything else. We went on our way. The sleeplessness kicked in just after the nausea. The blood test confirmed that I was pregnant, and Rob and I were already counting the weeks until our 12-week scan, desperate to see the baby, to get a sense of the thing that was apparently inside me. None of the websites I visited really got into the details of morning sickness. None of them warned me that brushing my teeth would make me gag, that drinking water would make me feel sicker than I ever have, and retch so hard that I would wet myself. Instead, they exhorted me to keep active, to avoid dehydration, to eat a bit but not too much, and to rest when I could. Sorry, a bit more, not a bit. The websites were keen to tell me how large my fetus was using the terminology of fruit and vegetables, a lentil, a pea, a grape. I imagine that women all around Australia expected to give birth to some kind of tropical smoothie by the end of their 9 months. My GP, I'll call her Clara, was pregnant herself and beaming with it. She made conciliatory noises and prescribed me Maxilon ginger tablets and vitamin B6, none of which worked. I spent hours in horrible corners of the internet in unregulated comment sections filled with anguished women who could not sleep and could not stop throwing up. I spent my sleepless nighttime hours looking for a cure to nausea, to insomnia, and to the panic I was beginning to feel. As I approached the 8-week mark, things became busier, and keeping my pregnancy secret at work became harder as I was so ill. I was teaching evening classes in the city and had to walk straight to my cousin's apartment because I was worried I'd vomit if I stepped onto a train or a tram straight after class. There were days I shut the door and lay on the floor in my office. Food made me feel both better and worse whenever I smelled or ate it. And perversely, apart from prescribing me, sorry, my cat wants some attention, Zofran, and entreating me to rest, nobody could do anything. As someone who had up until then felt nausea for 4 or 5 days at the most, I felt outraged by the thought that I would feel so sick for weeks or even months. How was I supposed to get to the end of my pregnancy? I didn't know, and neither, it seemed, did anyone else. By the time I was 10 weeks pregnant, my legs had been shaking for 2 solid weeks. My time in Sydney had been rushed, and I had a sleepless night there before getting home for our launch the next day. In desperation, I booked an appointment to see a GP a few days later. It was Clara's day off, so I saw someone else at the clinic. I arrived wearing a tracksuit, my hair dishevelled. I can't sleep, I told this new doctor. I can't seem to function anymore. I need help. She asked me if I'd tried listing the colours of the rainbow in bed. I stared at her. I couldn't believe she couldn't see the state that I was in. I told her I didn't know what was happening or why it was happening, that the only thing I could think that had caused this anxiety was the pregnancy. I would have an abortion, I said, if that meant the trembling would go away. She told me there were meditation apps I could get on my phone. She reminded me about the rainbow, and I left the clinic. I went home and rang the pregnancy hotline. They told me to go for a walk and take a shower. I love walking. I love going for long walks. I love looking at people's houses. The first thing I do when I'm in a new city is go for a walk. So I had my shower, headed out, but rather than calm me down, the walk made me more and more agitated. I was walking faster and faster and couldn't slow down. I didn't know what a panic attack was back then, but at that moment I felt like I might be having one. Rob was giving a presentation to the heads of his lab, so I didn't call him. I called my friend Miriam, who told me to go straight back to the clinic and she'd meet me there. I rang and told them I was coming in. I saw the same GP I'd seen that morning, the one who suggested rainbows, and she asked if we'd allow a more senior doctor to sit in on the appointment. I nodded vigorously. He came in and explained to Miriam rather than to me that I should be hospitalised because I had expressed a desire to harm my unborn child. Miriam was outraged. She argued that my consideration of an abortion was normal given the circumstances I was in. She told them they were being unreasonable. I sat there small and ashamed, unable to speak for myself. Miriam led me out of the clinic. You're never going back to that place again, she said. She made an appointment for me at her doctor's clinic the next week. The next day, my cousin suggested I might be going through a withdrawal to end it. She'd seen something similar with a friend. I'd managed to see Clara that Friday, and Sonia came with Rob and I for my appointment. When Sonia told Clara her theory, Clara agreed that it made sense, that I had the symptoms of someone going through a drug withdrawal. She prescribed me SSRIs, commonly used to treat depression and anxiety. She warned me that one of the side effects was increased anxiety. We were heading into a long weekend, so Clara told me that if my anxiety got worse, I should go to the hospital. The next day I went to my acupuncturist and she managed to steel my legs for the evening. I felt optimistic. By Sunday, however, the trembling had returned and worsened. By Sunday night, I was having suicidal thoughts and could not stop seeing images of babies being hurt. Rob rang our local CAT team, who said I needed to see a psychiatrist quickly, and the easiest way to do that was to go to the emergency at the Royal Melbourne. It was now around 1 a.m. The psychiatric nurse who assessed me recommended I stay in the psychiatric ward for the night so I could see a psychiatrist the next morning. I watched Rob walk out of the double doors to go home. The door sliding closed behind him made me realise that we now inhabited 2 different worlds. He was well. He was free to go home and go to sleep in our bed. I was not well and I had to stay behind. I had to be treated. As I watched him walk away from me down the hospital corridor, I felt a pang of envy followed by a terrible guilt about what I was inflicting on him. By this point, I'd seen 3 different GPs, 2 of them experienced, one of them who specialised in obstetrics. None of them had been able to figure out what was wrong with me. Only my cousin, who was a fashion designer, was able to pinpoint the cause of my restless legs. Even now, I shudder to think what would have happened to me and to my baby if Sonia had not had this experience. Sorry if anyone was expecting something a bit more enjoyable. In the book, I ended up interviewing other women because I didn't want my experience to be the only experience that I reflected upon. And so I just want to share a few of their experiences now. Okay. One of the things that made my terrible pregnancy bearable was the idea that it was a singular experience. Surely what I had gone through was a fluke or an aberration. Surely other women hadn't had the same experience. But what I found in writing about this subject is that I'm not unusual. Many women I've spoken to have experienced trauma at the hands of medical professionals. I interviewed 6 women from varying cultural backgrounds for the book. Their experiences aren't a complete sample. All of the women, I should note, who reached out to me were highly literate and feminist in their outlook. Several of them worked in healthcare, so I want to look at a few of their experiences here and finish up with the experience of a midwife and an obstetrician. So for some reason it's, there we go. Fiona's desire to speak to me was born of the frustration she felt as someone working in public health who'd had her pregnancy concerns dismissed or ignored. She told me, if anyone is able to assert their rights and be clear and articulate in an argument, it's me. So how does it work for people who aren't health literate or don't have the resources or the language or the ability to have these conversations? Fiona had received really great continuity of care in her first pregnancy and she wanted to replicate it in her second. She was conscious of her history of anxiety and depression and so wanted to put in place as many supports as possible so that something came up during the pregnancy or afterwards I was well supported. Her second pregnancy was complicated by her diagnosis of gestational diabetes, so she had to be monitored by both an obstetrician and midwife throughout. Yet to her dismay, she realised it wasn't the same obstetrician and midwife each time. It wasn't a pleasant experience, she said, mostly because of the lack of continuity. Nobody knew who I was, nobody knew what I needed, nobody knew my history. She found it ridiculous that there was less continuity of care in her high-risk pregnancy than her low-risk one. If you're considered high risk, you would think they would increase your need to have continuity of care, to have the same person laying eyes and laying hands on you. The consequence was that Fiona, a forthright and knowledgeable woman in public health, became passive in her care. She explains it this way. I didn't want to be seen as a troublemaker before the birth because I thought the implications would be that my care during labour would be different. I thought I'd be put with a particular midwife, or I'd definitely be put in a shared room, or that my service would be different if I was seen as a troublemaker. So at some point I sort of started pulling back, probably the closer I got to giving birth. The lack of care she received in her pregnancy and during her birth was traumatic, but the trauma went unacknowledged. There was never any psychological care, sorry. The computer's doing things without my permission now. She acknowledged psychological care offered to me through the public system. There was no mental health. There was no mention of my mental health at all in that hospital. There was no acknowledgement that that was in any way traumatic for me. Kala, a self-identified Black woman, was also categorised as high risk during her pregnancy, at particular risk of edema, though she can't recall anyone properly explaining why. She states that the health system made me very aware of my skin colour. These awarenesses range from comments about her skin to the cute little mixed race baby she would give birth to. A scan quite early on in her pregnancy revealed that Kala's baby only had one kidney. She was told that this sometimes happened and that the second kidney would appear in due course. She was told that the situation would be monitored, but as she recounts, it wasn't until pretty much my second last scan that they said, oh, actually, no, there's only one kidney. And there were 2 scans in between where they didn't check. I asked Kala if she was offered any counselling when she found out her baby would be born with only one kidney and therefore a life of health complications, and she doesn't recall this. For Kala, who is made to feel so aware of her racial identity throughout her entire pregnancy and birth, as I go into in the book, there are lingering questions about how much her ethnicity factored into her lax medical care. Corinne found it was hard to get professionals to listen to her concerns about her pregnancy. She recalls being in another city on a work trip when her GP called and told her to go to the nearest hospital. Her scans had just come back and the GP could not see a pregnancy even though Corinne had returned positive pregnancy tests and blood tests. She went to the emergency department at the nearest hospital and told them she was there on her doctor's orders, and her GP was concerned that Corinne might have an ectopic pregnancy. At the ED, Corinne had a hard time convincing the staff she needed to be seen right away. When they finally performed the blood test and found no evidence of pregnancy, one of the staff tried to discharge her, even though she told them that her doctor had ordered her to have an ultrasound before getting on a plane home. The only way Corinne could have her medical needs met was by getting the doctor attending her to speak to her GP on the phone. She put the hard word on him and said, "You really need to give her an ultrasound." And when they did, they found the ectopic. I'd argue that very few people involved in this model of pregnancy care, where the fetus is over-examined and the mother is barely listened to, benefits from it. Bridget has 25 years experience as a midwife in the Australian public hospital sector and in Asia and Africa with Doctors Without Borders. For Bridget, pregnancy and birth in Australia has changed dramatically over the past 2 decades. Sorry, they're my little birth results. She cites the rising rate of anxiety and depression she sees during pregnancy as the biggest area of concern, telling me that over 80% of women that I look after experience psychological difficulties. She says postnatal care would be the least funded area of medicine in Australia. They just want to get women in and out as quickly as possible. When I started midwifery, we used to run postnatal classes in the postnatal ward. They stayed for 5 days. Now I don't think we're preparing mothers well for motherhood, and I really feel desperately sad about that. For Diane, a senior obstetrician, a lack of resourcing is the #1 issue she faces. If we had more resources and more money and more people to do things, we could provide much better care, she explained. For her, the antenatal education in hospitals is not adequate. Midwives and obstetricians are not given enough time with each patient, which means that much of the information pregnant people need is simply not shared due to time restrictions. She thinks it's not a lack of female obstetricians that's a problem, but rather the way in which doctors are taught to care for their patients. She states there are times when we need to be paternalistic, but actually the majority of time we shouldn't be paternalistic. We can be recommending what we think is standard care and the care that they should take up, but in the end, it's a woman or patient's choice whether they want to accept that recommendation. Diane and Bridget both believe that the most pressing issue for medical practitioners and patients is a lack of time, which comes from a lack of funding. Both of them would like more time to care for patients and more continuity of care for each patient. So by the time birth comes round, strong relationships have been established and the pregnant person has been given all the information they need to have the kind of birth that they want. I asked both of them to describe their ideal system. Diane said, "I'd love to see a model where during pregnancy you've got 2 obstetricians, a group of midwives, and you've got a group of women allocated to that group, because then you've got continuity of caregiver, whether it's a midwife or a doctor and within a team. And the women are only going to see a few different faces and trust will be established." Bridget says, "If I could set the system up, I would have groups of midwives and obstetricians working together. All women would see midwives, a group, like a caseload or a small group, and then they would meet the obstetrician that's part of that group. And if there's a complication, they would be referred there. So everyone would be working the way they were trained. Midwives are trained to look after low-risk women, obstetricians trained to look after high-risk pregnancies and delivery. Then all women have access to both and they would know them, and then the schedule of care could be individualised." The main themes emerging from interviews I conducted with women who'd been pregnant and medical professionals were similar. The women had not felt well cared for and the medical professionals felt that they had not been able to adequately care for their patients. All of them cited a lack of time and lack of continuity of care as the biggest issues they faced. It's obvious that the paternalistic nature of the current medical system, as well as budgetary constraints for women's care during pregnancy, are responsible for this, as well as many, many other things I haven't been able to get into. What we don't know yet is the long-term effects of this lack of care on the women, their families, and our population at large. Thank you.
Thank you, Natalie, and thank you for sharing your experience. Even though you still have young children, you've managed to do that. And I think that's one reason why we don't hear a lot of those stories, because you just have to get on and do whatever it takes, to look after children and run a family and work and do everything, that women try and do. But I would like to sort of do a call out too, again, for your book, The Cost of Labour, because it's a really good read. with a lot of your personal experience, but I have to say I'm really quite well versed in the related literature, and I didn't know heaps of the references. So so it's
that
very
makes
up
me
to
feel
date.
very good. Thank you, Joan.
Yeah, so yeah, well worth a read, I'd say, that book.
Thank you.
So our next speaker tonight is Ellen O'Keefe. She's the president of Maternal Health Matters. She has a special interest in postnatal care and preparation for parenting. She has experience in health service planning and reproductive health education. Through Maternal Health Matters, Ellen hopes to see Australia rediscover pregnancy and birth as a family joy, not as an illness to be treated, where all health professionals have a role in ensuring that they provide evidence-based, respectful care, and that the women in their care are empowered to be equal partners in the process. So thank you, Ellen.
Thank you, Joan. Now, so I'm going to speak to women's experience of maternity care in Australia. When it comes, I would like to acknowledge the Ngunnawal people as the traditional owners and custodians on the land on which I stand today. Thank you, Natalie, for your presentation. It segues well into mine. During my presentation, I will include the voice of women by using extracts from our 2020 Dignity Survey, The Mother's Tale. And I want to point out at the beginning of this presentation that contrary to popular and medical opinion, pregnancy, while uncertain, is not dangerous for the majority of women. The World Health Organization states 85% of births do not require interventions, and when the caesarean section rate goes above 10%, there's no evidence that mortality rates improved. Sadly, maternity services often forget the significance of maternity for women. As one woman told us in the survey, this may be just another routine day at work for the doctor or the midwife, but for me, it's not just an ordinary day. This day has changed my life, turned it upside down. I don't think they remember that. We know that the care that a woman receives during maternity has the potential to affect her both physically and emotionally in the short term, as well as the health of her baby. The concept of safe maternity is usually restricted to physical safety at birth. Safe maternity is more than the prevention of death and disability. It's also about treating women with dignity, creating trust, and preventing harm. Women feeling disrespected during pregnancy and childbirth is an endemic phenomenon. The World Health Organization stresses it as a worldwide issue of concern. The recent history of maternity care is a study of disrespect, discrimination, bias, abuse, and control. We at Maternal Health Matters believe that all women are entitled to maternity care that protects their fundamental human rights to dignity, autonomy, privacy, choice, and to be free from harm and mistreatment. I echo Kate Gilmore, the former Deputy UN Human Rights Commissioner. She speaks of her wish for every female to have access to their human rights as necessary for their dignity. It's an interesting word, dignity. Dignity is a foundational value in human rights, ethics, politics, philosophy, and respect for maternity care. Dignity is evidenced by the values of respect, kindness, understanding, tolerance, and compassion. I suggest dignity is to maternity care what justice is to law. Dignity is a guiding principle in medical ethics and features prominently in codes of medical ethics. Article 1 of the Universal Declaration of Human Rights states that all human beings are born free and equal in dignity and rights. Australia is signatory to the Universal Declaration of Human Rights and is obliged to promote, protect and fulfil the right to health. This includes maternal and child health. For childbearing women, there are two cardinal principles. The principle of human dignity, the right of every human being to live a dignified life, a life worthy of honour and respect, and the principle of not using others as a means to an end. Yet, with the advent of technologies that see into the womb, the focus of care has shifted to the fetus and the pregnant woman has become a means to an end. She's almost invisible. I suggest we all know a loss of dignity when we see it or experience it. I'm embarrassed, uncomfortable, ashamed, shamed. In maternity care, dignified environments and the processes are those in which women's values and vulnerability are acknowledged and accommodated, where she is recognised, understood, treated with respect, fairness and accountability. A woman's values and goals contribute to what is in her best interests. She may have religious, cultural, psychological, social, or other priorities that frame her worldview and therefore dictate one course of an action over another. Notably, this may include distrust of the maternity system or the care provider. Human rights. A woman is not assigned a special class when she becomes pregnant. Like all human beings, she possesses basic human rights, such as in the slide. The World Health Organization states that access to appropriate maternity service and respect for human rights is essential to a positive maternity care experience. Disrespect can lead to women feeling degraded and dehumanized. Once a woman becomes pregnant, she is generally in a vulnerable position. How this is encountered and managed by the maternity care system and professionals may either increase or decrease such vulnerability. As a comparison, I suggest you think back to when you were starting a new job. You were really confident about starting that new job, but you were also vulnerable in those initial few weeks. There seems to be a strong relationship between power and vulnerability. Further, we can be quite surprised at how quickly a deterioration in our power raises our vulnerability. And this requires us to question and disrupt the very way we socially construct power in maternity care. As one woman said, whose fear are we managing, theirs or mine? The woman is not a vessel for carrying a baby. She's a living human being with rights. She's not a means to an ends. As one woman told us, it's not enough to get the baby out. We need to consider how it impacts on the health and well-being of the mother, both mentally and physically. It's such an important message for all working in maternity care to remember that they have an obligation to safeguard dignity, that compassion and respect sits at the very heart of good care and preventing harm. Yet treating women as an object enables the professionals and the organisations involved to dissociate and to tolerate acts of abuse, assault and violence against women and direct the focus of care to the fetus, with the woman being invisible. But where does the responsibility for dignity lie? Ensuring dignity and compassion in care requires commitments at all levels: government, health service organisation, professional groups, individuals. Obviously, each professional has a responsibility. However, the wider organisation must take some responsibility as well. We need to do more to create the conditions and enable staff to do the right thing. The truth is, while everyone thinks they have a right to dictate a woman's choices in pregnancy and birth, no one considers it their responsibility to pick up the pieces afterwards, particularly when, even with the best of intentions, things go wrong. Research tells us that when a woman is pregnant, that the protection provided by human rights is needed more. Disrespectful maternity care represents a dimension of violence against women and remains a significant public health issue. So much so that in 2019, the United Nations Special Rapporteur on Violence Against Women reported on obstetric violence and called Australia out as a particularly poor performer. Disrespect in maternity is part of a continuum of violence that women experience across their life. Violence is so ingrained in our society that it makes sense that it would then make its appearance in childbirth. This mistreatment is a complex problem that is a form of sex-based discrimination. However, due to harmful gender stereotypes about women's bodies and their inferior status within society, or their perceived inferior status, this behaviour is often normalised and rendered invisible. It brings to mind the comment, "You leave your dignity at the door when you enter maternity care." That's not true. This abuse can vary from verbal insults to refusal of information, not being listened to, not being engaged in decisions, authoritarian behaviour such as forced immobilisation, forced monitoring, an unwanted vaginal examination or episiotomy, or a refusal of pain relief. That is, any act that forces the pregnant woman to undergo something against her will, or which strips her of her dignity, including the problem of obstetric violence that arises in the context of over-medicalising birth and coercive control. Coercive control is used by maternity services so that women receive care that the services judge to be in her best interests. This approach relies too heavily on the care provider's context. We argue that the greater attention of the woman's values, goals, and situations and priorities will combat the issue of coercive control that currently pervades maternity care. Examples of this are threatening, saying that your baby may die. A classic one is that, do you know you were told you have an 100% increased risk of stillbirth after 39 weeks of pregnancy, so you should have an induction. It is true, you do have a 100% increased risk, but it's significantly insignificant. It goes from 1 in 1,000 births to 2 in 1,000 births. Okay, and it's also the routine application of novel evidence-based care. For example, continuous CTG monitoring that stops women choosing a comfortable position. Disrespect and abuse has been identified as a key deterrent to women seeking maternity care. We know free birthing is on the rise. Contrary to popular opinion, research demonstrates that free birth is not undertaken lightly or without preparation by women and is motivated by negative experiences in previous births. We need to acknowledge that obstetric violence is especially traumatising for family violence and sexual assault survivors. Maternity care has become a pathology. Pregnancy is a medical condition and it prioritises the needs of providers and utilises routine use of interventions that are not supported by reliable evidence. Current maternity spending by government is about $7 billion per year, yet with all the costly technology, pharmaceuticals and surgeries, we're not actually improving maternity outcomes. Dr. Robert Youngson comments that healthcare's focus on physical disease and biomedicine is unbalanced. We need to pay more attention to the emotional, psychological and spiritual well-being and the huge importance of healing relationships. The United Nations Population Fund states routine unnecessary intervention in birth is an ethical issue. Routine interventions violate a woman's autonomy, do harm and fail to achieve optimal outcomes for women and their newborn. Rigid protocols treat women as a machine, not a human being. One size does not fit all. This has been recognised by the World Health Organization in the Labour Care Guide, which aims to improve women's experience of childbirth and to help ensure the health and well-being of women and their babies. Yet this guideline is yet to be implemented widely throughout the world and in Australia. The pathologized medical approach to maternity care is at odds with the reliable evidence that pregnancy and childbirth are normal physiological events for most women. That said, when this model applies to women and their infants who need intervention, it is medicine at its best. It is beautiful medicine. It transforms lives. It saves lives. I echo Mary Kirk in that statement. When applied to all women, however, it has a potential to cause harm and it violates an underpinning principle of medicine itself. Above all, do no harm. In Australia, we're seeing more prematurity, more infant mortality, more perinatal mortality, and poor outcomes from maternity care. For example, do you know that there's been no major change in maternal mortality in over 30 years, and there has been increasing maternal harm or morbidity? 1/3 of women who birth annually, that's 100,000 women, report birth trauma, and 2/3 of this is due to disrespectful treatment. 1/3 of women who have birth trauma go on to experience post-traumatic stress disorder. Only 10% of women can access continuity midwifery care, the best evidence maternity care that reduces preterm birth, stillbirth, and complications in pregnancy. Caesarean rates at 36% are nearly 3 times the recommended rate by the World Health Organization, and we have significantly higher rates in city births and hospital births compared to rural and country births. 43% of low-risk women are having their labour induced, and many are reporting not even giving informed consent for this procedure. We have an increase in 3rd and 4th degree tears. We have an increase in postpartum hemorrhages. Preterm birth rates among Aboriginal babies is between 2 and 7 times that of non-Indigenous babies. Add babies and partners, and this is a significant number of people affected annually, 900,000 people, nearly 1 million. Medicalising maternity care gets in the way of a successful breastfeeding and denies the inalienable right of women to breastfeed and for their infants to be breastfed. We believe breastfeeding is an inherent right that should be protected, promoted and supported. When a woman's expectations regarding her pregnancy, delivery, infant support and sense of self are compromised, she is more likely to experience lower levels of self-esteem and higher levels of depression, anxiety and stress. Not a good way to start your mothering career. And what of the long-term impact of lost income and productivity as a result of birth harm? It is the woman who wears the financial burden of going treatment and loss of income when they are harmed during maternity care. I ask, knowing what we know now, why do we continue to disadvantage our mothers' and children's health by interfering with the normal under the guise of safety so as to mitigate a perceived risk? Why is this so? There's so many reasons that I actually needed 2 slides. Pregnancy has been defined as an illness. The focus of care is the baby, not the dyad. There's much fear around birthing, particularly amongst health professionals, fear of loss of reputation, fear of poor risk. Discrimination is an issue, lack of governance, accountability and evaluation, and there's significant restrictive practices. Access to Medicare and visiting rights for midwives impact on maternity care for women. Risk factors have become to be seen as dangerous in themselves, even in a situation where they pose little threat to the woman who have them. When there is no clear dividing line between who is normal and who is high risk, the line is frequently drawn in such a way that a maximum number of people are labelled at risk and therefore become candidates for unnecessary interventions. As one woman was told when she was asked to consent to induction, by her medical provider, I'm trying to prevent a catastrophic event. We also need to acknowledge that certain groups profit from the idea that birth is risky and that their knowledge, technology, institutions, protocols supposedly have the ability to reduce risk. I would question that. And more reasons why this is so. We actually ignore the evidence. We continue with custom and practice rather than applying the new research. The system is driven by the legal system and the insurance system. We're all about convenience. There's structural and horizontal violence and technology, drugs are profiteering from this system. There's poor service design, and unfortunately for women, there's poor health literacy. Contempt. I want to introduce the concept of contempt. I suggest that women are held in contempt by the healthcare system in line with the cultural view of pregnancy and birth that stems from a patriarchal attitude that women must be submissive and passive and that the experts who know better do the work. Australia doesn't have a pregnant women problem. It is very clearly a health professional and maternity services problem. Patriarchy built the current maternity care system, and patriarchy still largely holds the power and sets the culture. Patronising can end, while not malevolent, though through entitlement and assumed position of superiority, can easily tip over into violence when that superiority is challenging. In this kind of contempt, the direction of knowledge, of communication, of effective action is only ever one way. The woman's knowledge is not acknowledged, it's not sought. Condescending contempt is the contempt of professionals for clients, men for women, masters for servants, and bosses for workers, whites for coloured people, the educated for the uneducated. This sort of contempt reflects and perhaps reinforces a hierarchical order and in our society, patriarchy. Rejecting a woman's request because it doesn't align with the professional or health services conceived idea of quality of care shows contempt for the woman's authority and dignity. Contempt leads to blame. The woman is at fault when things go wrong. The mantra is too old, too fat, too sick. When we embrace responsibility instead of blame, we stop worrying who caused the problem and begin focus on what can be done to solve the problem. How can it be resolved? We at Maternal Health Matters say it starts with respect. It's as simple as that. We need to see beyond the pregnant body and recognise the woman as fellow humans, emphasising the rights of women to dignified, respectable healthcare throughout pregnancy and birth. We need to involve all stakeholders, but most especially women, in efforts to improve quality of care and eliminate disrespectful and abusive practices. Greater support from government is required to address disrespect and abuse. Government can set the standard for care. We need to initiate, support and sustain programs designed to improve quality maternal care with a strong focus on respectful care. We need to generate data related to respect and disrespect. We need systems of accountability and meaningful professional support. Respect starts with listening to women with the lived experience of discrimination, harassment and abuse. Without women's testimonies bearing witness to what they experience in childbearing, we have no course open to us for true and sustainable solution to the respect for autonomy, lack of dignity in maternity care. And how stories are not enough. Without political will, nothing will change. The WHO statement for the prevention and elimination of disrespect or abuse during childbirth calls for greater action, dialogue, research and advocacy on this important public health and human rights issue. I'd suggest that we actually know what is wrong and the solutions, and more importantly, we need action. Only then will women receive humane, respectful, safe, satisfying models of maternity care. Our survey, The Mother's Tale on Dignity in Maternity Care, paints a mixed picture. Our findings indicate that the human right to health has been breached in relation to availability, accessibility, acceptability, quality, respect, and quality. We asked women how could maternity care be improved, and interesting enough, 4 themes emerged. Provide respectful care. Women know what that is. Provide continuity of care, preferably with a known midwife. Improve postnatal care and provide options on care. Improve health literacy. The biggest impact on maternity outcomes will be where a woman births, who provides maternity care, and in what model of care. These choices are the first step towards a healthy and happy start for both mother and child. To make their own decisions, women require accurate, factual, unbiased information. Women told us they wanted to know their options. They wanted data to inform their decisions. Women recommended access to information about birthing options, locations, models of care, support options, and outcomes of care. One wonders if we need a My Maternity portal. Women reported restrictive referral pathways via their GP. GPs restrict women's knowledge of their options because once a woman is in the medical system, that is the way they're shown. When women decide on a preferred option, their access is limited by the number of spaces available. Women want continuity of care. However, that's not available to them and they're forced to make other decisions. And consequently, we then don't increase the number of continuity of care places. To overcome some of these issues, we've developed the maternal health toolbox to support and inform women when making decisions. Respect. What is respectful care?
Sorry, Ellen, just watch the time. It's if you could finish up soon.
Yeah, I'll finish in about 5 minutes, I think. Yeah.
Oh, that's over. Yeah, if you could go a bit quicker, that's it's a bit over now.
Okay, sorry.
Yep.
We know that the basic principles of respectful care are sometimes neglected in healthcare facilities. Investigations into curtailing maternity services have repeatedly shown a profound lack of respect for human rights that have gone hand in hand with clinical and system failings which compromise safety. Most recently in Australia, we refer you to the Mackay Hospital. Continuity care is the gold standard care referenced by WHO, Lancet and Cochrane, how it is under threat in Australia. Women do not receive continuity care. Well, postnatal care is a real issue, and Natalie's spoken to that. The way forward, a care that does no harm, is culturally sensitive, is valued by the women and valued by the community. A metaphor that I think is important is respectful maternity care is to maternity care as is hand washing is to COVID in today's context. The Respectful Maternity Charter is a tool to achieve change. It's a framework grounded in law. Law matters. It's not about personal opinion and it's not about professional opinion. It's about right and wrong, what is lawful and what's not lawful. One element of the Respectful Maternity Care Charter is the right to be free from harm and ill treatment. This is rooted in the Convention Against Cruel, Inhumane and Degrading Treatment Against Torture. On the World Patient Safety Day in 2021, WHO launched a campaign focused on safe and respectful maternity care, given the high levels of abuse and mistreatment, especially in high-income countries like Australia. and the future, we started with the concept of dignity. True dignity in care includes deference to the woman each step of the way, unbiased information so as to make an informed decision and give a fully informed consent, and support instead of coercion or pressure about the decisions. I've got about 2 minutes. I believe in understanding, embedding and monitoring dignity in maternity care has the potential to make real differences to a woman's experience. Australia needs to ensure responsive, sensitive maternity care systems that cater for the individual woman in respect to her human rights. The linking of quality care with a human rights approach to the health is the intent of the Respectful Maternity Care Charter. As a society, until we value childbearing and knowledge that a woman having a baby provides community good at significant personal cost, nothing will change. With so much resting on a mother's shoulders, it's vital she be given the support she needs for her well-being so that she can care for her family and her children. Sorry for going over time, and thank you.
Thank you, Ellen. There's so much to be said, clearly, and it's great that it's recorded because it's the kind of thing that might be good to watch again at some time because there's so much content there, but certainly followed it on really well from Natalie. So thank you, Ellen. So our next speaker is Stephanie Brown. Over the last 15 years, Professor Stephanie Brown has developed a vibrant program of epidemiological and health services research with a primary focus on reducing health inequalities. Her team is working with Aboriginal and refugee communities and women and children exposed to family violence to address gaps in evidence regarding effective intervention strategies to promote resilience and enable healing and recovery from the effects of trauma and family violence. So thank you, Stephanie.
Thank you very much, Joan, for that warm introduction. My goodness, we are tackling big subjects tonight, and I'm conscious that I'm now sort of sitting between you and a chance to discuss them. So I am going to try and keep this presentation as brief as I can. But I would like to acknowledge country, the traditional owners of the lands and waters of the country that we now call Australia, lands and seas that were never ceded. This is a picture from bushland along the Bunurong coast. I have the good fortune to live and work some of the time down in southeastern Victoria. So I was there yesterday when I was writing this presentation. So I just wanted to acknowledge that. It's really a privilege to live and work on these lands, and I'm deeply grateful to the traditional owners and their elders, past, present and emerging. Today, what I'm going to do is introduce you to the stories of 3 women at different stages of the first 10 years of motherhood. So we're going to move our sights, we're going to move through pregnancy and the first year and right out to 10 years after having a first child. The stories are stories that have been shared with us by women that have been Victorian women that have been taking part in a longitudinal study that our group is leading. The study's been going now for almost 20 years, and women joined the study when they were pregnant with their first child. The names of the women, of course, are fictional, and the stories bring together stories from different women in the study. Starting with Amy. And I'm going to ask you, I know it's late, but I'm going to ask you to listen very deeply to these women's stories. We've just had a really big presentation with a lot of theoretical concepts and really important human rights issues. I'd like you to change gear a little bit and bring yourselves really present into this presentation. Perhaps you might want to take a couple of deep breaths, or you might even like to close your eyes as I share their stories. With just a content note before I start, if these stories happen to resonate with any aspects of your own life experience or the life experience of family and friends, then I very much hope that everything that's said by me and in the discussion is compassionate to that experience. Turning to Amy, at the time of our contact with Amy, our first contact with Amy, well, actually, that wasn't our first contact, but this story. At the time of our contact, Amy has a 1-year-old. She's living in New South Wales with her sister. She had her first baby at a public maternity hospital in Melbourne. And during her pregnancy, her partner came to every pregnancy appointment. He developed a really good relationship with the midwives at the birth centre that they were both attending, and they liked him. At home and behind closed doors, he was often abusive, physically, emotionally, and sometimes sexually. Amy's health suffered. She became extremely anxious. She got frequent migraines, and as her pregnancy continued, she developed severe urinary and fecal incontinence. Amy had no family nearby, and she didn't tell them what was happening during her pregnancy. She thought about talking to the midwives or to her GP, but she rarely saw them alone. And when she did, she couldn't actually find the words. Because we have the stories of 1,500 women in our longitudinal study, we can put the information that Amy shared with us into context. So we know, for example, that 6% of women in the study told us that they were afraid of their current partner or a former partner during their pregnancy. And those women that told us that were 10 times more likely to experience anxiety symptoms during pregnancy, 4 times more likely to experience depressive symptoms, 3 times more likely to report vaginal bleeding, and also more likely, 2 to 3 times more likely to experience urinary and fecal incontinence. In the first year after having their first baby, of all the women in the study, 19%, 1 in 5, had experienced emotional or physical violence in that first 12 months after having their first baby. And they were also more likely to experience depressive symptoms, anxiety symptoms, poor physical health, and they also reported to us that they were experiencing pain during sex. So a lot of things were going on for women with this life experience, and so many women having this life experience. Now I'm going to introduce you to Narasha. Narasha has a 4-year-old and a 1-year-old. She had a miscarriage between her 2 pregnancies. She's living with her husband in an outer suburb of Melbourne, and her parents are living overseas. She has a brother living in Melbourne, but she rarely sees him because he's very busy with his own family. Narasha's husband lost his job last year, and since then he's only had casual jobs. He has been drinking heavily and gambling, and sometimes gets angry and blames Narasha. He won't let her talk to her parents on the phone unless he is present. They don't have enough money to pay the rent, and Narasha sometimes goes without meals. Narasha told us that she went to see her GP recently, and the GP did a mental health plan and referred her to a psychologist. She went once to see the psychologist, but didn't go back again because of the cost. She didn't tell her GP or the psychologist about her husband's behaviour or their financial situation. Again, we can put Narasha's story in context by looking at the information that women collectively gave us about their life experience. So the 4th year after having their first child, very similar proportion of women, roughly 1 in 5 or 20%, were experiencing partner violence. They weren't necessarily all the same women. There's quite a bit of variability in this experience. So overall, we saw that 29% of women in the study at this point in time had experienced partner violence since the birth of their first child. And women with recent experiences, so experiences in the past year, in that 4th year of motherhood, recent experiences of partner violence, were 3 times more likely to experience depressive symptoms, twice as likely to be reporting that they were taking psychotropic medication, and 3 times more likely to have a child who was at this stage experiencing emotional or behavioural difficulties. And now turning to Dana. Dana's son is 10 years old. They live together in a 2-bedroom rented house in a small regional town in Victoria. Dana's son regularly spends time with his father, who lives about 30 minutes drive away from them. They had a messy divorce 2 years ago, and Dana is still recovering from the events leading up to it. She tries not to think about this, but still has nightmares and suffers with bouts of depression. Last year, she was diagnosed with high blood pressure and now takes medication for this. Dana is worried about her son. He is more and more argumentative, and lately he has been refusing to go to school. She knows she needs help, but she's not sure who to turn to. She's still going to the same GP that her ex-partner goes to, and she hasn't told her GP the full story. And Dana's really like many women in our study. In this 10th year of motherhood, again, close to 1 in 5, 18% this time, had experienced partner violence in the past year. But by this stage, 10 years after having a first child, 1 in 3 women in the study have had experiences of emotional or physical violence with a partner or with a current partner or with an ex-partner, because violence doesn't go away when relationships end, unfortunately. Women with recent experiences of partner violence were again more likely to be experiencing depressive symptoms and anxiety symptoms, much more likely to be reporting post-traumatic stress symptoms, 4 times more likely to be experiencing thoughts of suicide, and twice as likely to have high blood pressure, heart disease, or diabetes. So big health impacts. And for their children growing up in households where there's been recent violence between their caregivers were twice as likely to be experiencing emotional behavioural difficulties at the age of 10, twice as likely to have a psychiatric diagnosis, and twice as likely to have sleep problems. So we're also seeing impacts for the children, as you might expect. Just want to show you these data in another way, because I've already referenced them as we've been going through 3 women's stories. This diagram just really gives us a picture of how common partner violence is in the first decade after having a first child. So at each of the points we had contact with women. Roughly 1 in 5 women had experienced partner violence in the previous year. And then by the time that children are 10 years of age, 1 in 3 women have had experiences of partner violence with a current or previous partner. We've talked to women about all sorts of things, but just for this presentation, I wanted to focus on the services that women turn to for support. It links back to the commentary we've already had about women's experiences of maternity care. But the data I'm going to share with you are the services that women are talking to when they're experiencing violence in their relationship in the 10th year after having their first child. Probably not that different to what the data would look like if we were to be talking about the first 12 months. Almost all women in the study had seen their GP at least once in the previous year, and that was just as true for women experiencing partner violence. If anything, women experiencing recent violence were a little bit more likely to have seen their GP in the past year. And 63% of women experiencing recent violence had seen their GP 3 or more times. So really frequent contact with primary care. About 40% of women had contact with a mental health professional in a counselling service or a psychologist. A quarter of women had sought support from a legal service, and small numbers of women had phoned a telephone helpline or financial counselling service. The message I really want to leave you with is this one. Although women have a lot of contact with primary care and mental health care, 2 in 3 women experiencing recent partner violence had not talked to a health professional about that experience.
Yeah, thank you, Stephanie, and a terrific companion with the other presentations. There's so much that obviously can be said. Well, thank you, everyone. I think we better finish up soon, that we've gone over a bit, but please watch out for our second one in this 4-part series, Birthing, Work and Matrescence, the Neglected Aspect of Maternity Care. That'll be in March 2023. See our homepage for the position statements and other information. And if you'd like to join the Maternal Health Matters, email info@maternalhealthmatters.org.au. And Ellen, you'll finish off for us tonight with thank yous.
Thank you, Joan. Well, I want to thank the Gender Institute for collaborating with us with Maternal Health Matters and enabling this series to be delivered. To the speakers, we thank you for your generous donation of time, insights, and your presentation. The presentations really complemented each other, highlighting the impact of care across the lifespan and its particular impact for women. To our IT supports and moderators, thank you for streamlining the seminar process. To Joan, without your vision and perseverance, we would not be here tonight. Thank you for creating the seminar series as a way to share stories, research, and to build awareness of the hidden epidemic maternal health. Your effort has been really, really appreciated. We hope you found the seminar series interesting and informative, and we look forward to further collaboration with the Gender Institute and to seeing you all again at our second seminar. Let's also remember that healthy mothers make healthy babies, make healthy nations.